Welcome, everybody. I'm Dr. Joseph Shams. I am Director of American Endovascular Care in Manhattan, and I'd like to bring you a very interesting case today regarding chronic limb ischemia. This is a 38-year-old male. He's over 300 pounds. He presents with a large, poorly healing ulceration of his left heel. This ulceration has been present for greater than 6 months, actually almost a year, prior to consultation to our service. The patient suffers from a skin condition called hidradenitis suppurativa, and he cannot be touched in either groin without severe pain, so groin access is not an option. Past medical history, significant for hypertension, diabetes mellitus, hyperlipidemia. He has history of coronary artery disease status post-MI with no previous stenting in the past, also end-stage renal disease on hemodialysis. His medications include Citalopram, Renagel, Januvia, Atorvastatin, zinc, Clindamycin, and Rifampin. On physical exam, he's alert and oriented ×3. He is 6'2" tall and weighs 300 pounds, elevated BMI to 38.5. Pulse is 93 per minute and regular, blood pressure 155/98, respiratory rate 16 per minute, temperature is 8 febrile, and his oxygen saturation is 98%. On pulse examination, he has non-palpable dorsalis pedis and posterior tibial artery pulses bilaterally. On manual Doppler exam, there's a monophasic signal in the left dorsalis pedis artery with a non-Dopplerable posterior tibial artery signal. There's a 5-centimeter necrotic ulcer of the left heel with a mucousy, non-malodorous, non-purulent discharge. Also noted are bilateral calf skin changes, which are consistent with venous insufficiency. For the plan, lab evaluation, begin antiplatelet therapy, arterial imaging, and Doppler. And this was unfortunately limited secondary to patient body habitus and inability to tolerate the exam. So our treatment plan was to perform a diagnostic angiogram via a left brachial arterial route through his AV access, and then revascularization via various routes. Okay, so this is a picture of a poorly, this is a necrotic left heel ulcer, quite large. Lower extremity angiogram via the left arm approach. So this is an angiogram that was performed through the patient's left arm AV fistula. Here we see an aneurysmally dilated juxtanastomotic segment of the fistula. This is a transposed basilic vein fistula. It was accessed in retrograde fashion in the fistula, and now we're advancing a catheter and guide wire up the brachial artery, and actually was advanced beyond the subclavian artery and down into the descending aorta. And on the right side, we can see a picture of a pigtail catheter from the arm, which is inside in the abdominal aorta, and we see an aortogram with normal aorta and iliac vessels bilaterally. This is a selective left lower extremity angiogram. Here we have the proximal superficial femoral artery is the deep femoral artery. We see in the mid to distal portion of the superficial femoral artery has about a 70% eccentric stenosis within the distal superficial femoral artery. Here's the picture on the right is a subtracted image of the popliteal artery, which is somewhat irregular, but normally mild irregularity. And then we see just a proximal portion of the anterior tibial artery and the tibioperoneal trunk, which is open. Okay, here's some selected images of the left lower extremity runoff. We see that there's a stenosis in the upper portion of the popliteal artery, of the anterior tibial artery, and also a high-grade stenosis in the proximal portion of the anterior tibial artery. The tibioperoneal trunk is patent. There's the peroneal artery is thread-like in caliber and diffusely attenuated distally with areas of high-grade stenosis and even some small focal occlusions, and the posterior tibial artery occludes beyond its proximal portion. On the right side, you see a transpedal access was performed with puncture of the anterior tibial artery in retrograde fashion. We do see that the anterior tibial artery is patent distally and supplies the dorsalis pedis artery within the foot. So at this point, we decided to treat the superficial femoral artery and anterior tibial artery stenoses atherectomy of the superficial femoral artery stenosis was performed using a 1.25 millimeter burr CSI orbital atherectomy device, followed by percutaneous angioplasty with a 6 millimeter diameter angioplasty balloon. The anterior tibial artery stenoses were also treated with atherectomy using the CSI device with dilatation with 3 millimeter diameter angioplasty balloon with an excellent result. And here we see the final, there was also stenosis distally, which we also treated. And we do see that even with flow, we have much better flow down the leg, and we do have some filling of the distal perineal artery from collateral here, but it's not direct line flow. So we decided we were going to bring the patient back in a couple of days. We brought him back 5 days later and performed an antegrade popliteal artery puncture of his popliteal artery from a lateral approach. So we actually punctured the popliteal artery from a lateral approach in this 300-pound guy, going downgoing, so going towards the foot. And here is our catheter inside the popliteal artery. We do see some mild irregularity within the distal portion of the popliteal artery. We do see our anterior tibial artery and the diseased proximal tibio-perineal trunk and proximal perineal artery. On the right side, this is a non-subtracted view of the perineal artery, which is diffusely diseased and irregular throughout its course. The posterior tibial artery occludes beyond its proximal portion. So we felt that we had to get one of these vessels open in order to get direct line flow to the area of the wound. Here's a better subtracted view showing the anterior tibial artery and the very severely diseased perineal artery, which seems to be occluded distally, and then the posterior tibial artery occludes in the proximal portion. On the right side is, again, view of the anterior tibial artery going into the foot. There is a plantar pedal arch and have some reconstitution of the lateral plantar artery within the foot. So we again performed orbital atherectomy of the perineal artery using the CSI device, again with dilatation with 2.5 and 3 millimeter diameter Sabre angioplasty balloons. And this is our final result with a widely patent perineal artery going all the way down to the distal calf. And here now we see direct line flow into the perineal artery and flow into the posterior portion of the heel with good flow to the area of the ulceration. Here's some before and after images. So here was the original image of the ulceration. In the middle, we see after this is right after the first, the 5 days later after the first angiogram, we do the second angiogram, and this is 1 week post the second angiogram. We see a nice beefy wound with good granulation tissue, and it's on its way to healing well. So, discussion of the case. Difficult access requires knowledge of alternate access routes, including transpedal approach, which we perform routinely, transbrachial, either through an AV access or directly from a transbrachial or transradial approach, and then transpopliteal or directly into the SFA. Goal is to attempt to reestablish straight line flow to the area of the wound to optimize healing potential. Aggressive revascularization is required for healing of chronic wounds, and obviously appropriate local wound care is essential once the area has been revascularized. Thank you very much, and have a great day.